All right.
Let's just confirm that you can see my screen. Wonderful. Well, it's a pleasure to be here, and Mandy, thank you for this invitation. So yeah, I'm Christopher King. I am dean of the School of Health, a new school at Georgetown. We launched it last year, and we're doing some interesting work over here as we think about what does it take to improve the health of the nation via an equity lens and recognizing our history and systemic racism and the role that it's played in many of these awful outcomes that we're also familiar with. So it's just an honor to serve in this capacity. We're looking at everything from how we train students to how we do our work in the community, to how we tell our story, to how does co-creating, what does that look like? I'll talk a lot about that today. Um, and this work is so important, and the work that you do is so important. Just think of we're on the other side of the pandemic, but there'll be another pandemic, and now is the time for us to mobilize and get ready. So that's what I'm doing. I'm an associate professor in the Department of Health Management and Policy. And before I came to Georgetown, I was a vice president at MedStar Health, where I oversaw community health. And so this work is very, very familiar to me. It's in my blood, doing work in the community. I've done many community health needs assessments, really just asking patients or community members about their healthcare experiences and their home experiences, the state of their community, and what's keeping them from living their full health potential, and taking that information and documenting it and coming up with interventions to make a difference. So it's wonderful work that we all do, and I'm glad that we have this time this morning to talk a little bit more about it. So the title of the slide, the title of this talk, I think I called it, Race, Place, and Structural Racism, a Review of Health and History in Washington, D.C. And I know that you all have access to the publication that supports this particular talk. If some of you've had an opportunity to read it, we published this paper last year because we've been talking a lot about disparities in DC for so long, right? But we hadn't seen a publication that really tells the history of the city. So we went all the way back to the beginning of the start of the District of Columbia, 1790, and we identified milestones during that time period since 1790 that really did disenfranchise, harm, traumatize Black residents. And it helps us understand why things are the way they are today. So that's what inspired the paper. So we'll come back to that in just a few minutes. These are the objectives, and these are the same objectives that I think you've seen. I always like to start my talks off with this slide because it really tells the story that something is awry here, right? What you see here are life expectancy on the vertical axis, and on the horizontal axis, you see spending per capita. And plotted along these lines are industrialized countries. So you can see where we fall. We are all the way over here, almost off the charts, the United States. We're spending a heck of a lot more than other countries, and our life expectancy is among the lowest. That's a problem, and I would argue that we cannot continue in this trajectory because a sick country is not a productive country, and we will not be able to maintain our place in the global market or improve our position in the global market. We also know that disparities and inequities are a key driver for these costs, and that's what this slide is showing here, right? It's like these disparities, which are measurable, are caused by inequitable conditions. So when we say inequity, we're just talking about when folks just don't have access to the same level of opportunity. So you have people on the south side of Main Street don't have access to the same opportunities as folks on the north side of Main Street. And over time, you're going to see differences in the health of those populations when you compare them over time. And then another piece that I always start off with is this need for us to have this paradigm shift, because we're spending $4 trillion a year on medical care in this country, I argue that we're not spending dollars on healthcare. We're spending dollars on medical care because the United States healthcare delivery system is biomedically centered. If we're trying to truly improve the health of people, of communities, we have to evolve and have a biopsychosocial approach to how we think about caring for people, how we pay for caring for people, how we prevent disease and illness. We have to think much more comprehensive. And we're just not there yet. We're not there yet, but we're seeing some progress. I know you've seen this before. You know, these are just the factors that shape our health, recognizing that clinical care is, you know, just about 20%. So everything else is what's happening in our home environments. And that's why the work that we're doing with this funding is so very important. It's also important to, again, go back in time and look at slavery and segregation and how, if you do the math, approximately 83% of the time, slavery and segregation have been normalized. It was normal, it was routine, it was in our society, right? And I would argue we're not even in the green zone. We're going to redo this because I don't think it's an accurate depiction, because the reason I say we're not in the green zone is because of mass incarceration, voter suppression, George Floyd, Breonna Taylor, and so many others. So we're not there yet. But this just goes to show you that because of this isn't something that can be fixed overnight, right? And so many communities, families have been harmed and traumatized because of slavery, because of segregation, and that plays out in our health. And that is one of the reasons we see such stark differences in the health outcomes of people of color when we compare to our white counterparts. If we had a little more time, I'd love to get some discussion on this, but just want to let you know that DC has been ranked high when it comes to the health of its residents. I think a couple years ago, it's the American Fitness Index that does this. They ranked us as #1 a few years ago. So we've always been in the top 5 since, I'd say, probably the past 5 years. That's very misleading when these types of headlines emerge, because this doesn't tell the true story, right? If we stratify data by race and ethnicity, by income, it is a very, very different story. And that's the story that we tell in these reports that we produce. We talk about how the city is segregated, and this clearly shows that. There's a measure, it's called the Residential Segregation Index, and it's a public health measure. And the reason the Residential Segregation Index is a public health measure is because the more segregated a community is, the more stark we'll see disparities. And so David Williams, who's a wonderful researcher out of Harvard, has done a lot of research that shows that when we are an integrated community, the bar is lifted for all people. All right, this should be familiar to you because it's what we depicted in the article. This is our lovely District of Columbia, and you can see, if you look at the right-hand side, Ward 7, Ward 8, and parts of Ward 5, we'll see some serious disparities. We looked at life expectancy and we looked at infant mortality because we know that those two indicators really do give us a sense of how healthy a community is. And so the lowest life expectancies east of the river, and I can look at a map like this and tell you Ward 7, Ward 8, housing, the property values are going to be lower. Educational outcomes are going to be lower when you compare it to the other side of the city and just a few miles away. The 3FS is full service. So there were historically 3 full service grocery stores to accommodate 180,000 residents in Ward 7 and Ward 8. And in Ward 160,000 residents. And in Ward 3, just so you have context, which is only 80,000 residents, 16 full service grocery stores, right? This is a major disparity. And we wonder why health outcomes are so different. Well, this is part of the reason. And again, this is just one measure. There's a lot of other measures we can consider if we really want to dig deeper into this. Morbidity, mortality. We made this very simple. We compared Black residents with white residents, and you can see the differences here. Note deaths due to diabetes 8 times higher in Blacks when compared to whites. And you can look at lung cancer, and you can look at all of the common types, and you'll see some disparities there as well. Why do we see these differences? All right. Again, I feel like I'm speaking to the choir because I know that this is the work that you do each and every day, but I'm hoping that maybe something or the way that I say it or express it can light a bulb or stimulate you in different ways in how we think about our work. So I'd like to think about them in 2 categories, systemic and individual, right? There's some systemic issues that help us understand why we see these stark disparities in cancer outcomes, for example. Obviously, costs, insurance, operational barriers, and what we classify those as, I can't see my doctor because, the clinic hours aren't convenient for me because of my employment, or I call to make an appointment, but I can't call. I have to do everything through the internet. I don't want to use the internet, so I just delay care. Or no one speaks my language when I call to make an appointment. So those are operational barriers. Transportation, of course, bias and discrimination that's heavily documented in the literature, and of course, systemic racism. And you can think of systemic racism in 2 buckets as well. Within the walls of our institutions, yes, that does happen, also known as institutional racism. And then beyond the walls or in our broader ecosystem, there's racism. And so these factors all of these on the left-hand side are systemic and help us understand why we see these higher rates of morbidity and mortality, particularly in people of color in the District of Columbia. Individual, these are more personal attributes, culture, attitude, social support. We know social support is very important. My mother was diagnosed with cancer 3 years ago, and she has us and family, and we're with her, and we take her to her appointments. That's important. And so when folks don't have those types of social support, that system, it can really cause them to delay or defer care, or to even forego care. Nativity, language, that should be acculturation barriers, meaning folks who may not have been born in the United States, who really haven't assimilated into our culture, or just the way we do things in the States. That's a barrier for many people. Education, distrust, of course, employment barriers, when folks who just can't take time. They don't have the luxury to take time off work to see for their medical appointments or other types of important services that can help them with their conditions. And this is a link here, and you can click on this, and it'll take you to some research that I did a few years ago, where we looked at about 12,000 adult survivors who delayed care. So we looked at folks who were diagnosed with cancer at some point in their lives, and they delayed care. We wanted to know what were the leading causes of delaying care. In our work, we found it to be cost, number 1. Operational barriers was number 2, and transportation was number 3. Place does matter. We also looked at Ward 3 and Ward 8. We wanted to compare the 2 most vastly different wards in our city. And you can see, my goodness, look at the income disparity and education, life expectancy, 16 years, a 16-year difference between Ward 3 and Ward 8. Infant mortality, 6 times higher in Ward 8. Heart disease, 4 times higher. So place truly does matter, even though it's just a couple of miles away when we're going from ward to ward. COVID, again, we look at, and we've been looking at this since the onset of COVID. It's been fairly consistent that 3 out of 4 deaths in the District of Columbia are Black. So how do we explain these trends? It goes back to the paper, and that's what we attempted to do. We looked at the history of the city going back to 1790. We captured, taxation without representation. That has health implications for us, especially during a public health emergency. For example, when COVID happened, other states, even states that have less population than we do, I think it's Wyoming, and I can't remember, there's 2 states in the country that have less than 700,000 people. That's around how many residents live in the District of Columbia. They got more money for COVID than we did because we're not a state. We didn't get as much. And so it shows up. We also saw this with HIV, AIDS in the 80s, how we weren't able to secure dollars, particularly around the needle exchange program, because our budget has to be approved by Congress. And they said, nope, we're not using these dollars for needle exchange programs. And so we depended on philanthropy. So yes, because we are not represented and taxation without representation, it does have implications for us as residents, and especially in the wake of a public health emergency. I'm not going to go through all of these, but St. Elizabeth's, at one point when it was built, was the nation's premier mental institution, psychiatric institution, and some really, really bad things were done to Black and brown people at St. Elizabeth's. People who live and are from the city know these stories. They talk about these things. Redlining, demolition of Berry Farms, which was once an affluent community in DC. Eminent domain. I mean, they wiped away very wealthy families, affluent families, not wealthy, affluent families, and they had to leave. And yeah, it's just really, and then the crack epidemic in the 1980s and 1990s, closure of hospitals we saw between 2001, DC General, Providence, and a few others. So as we think about our work and the work that you're doing, hopefully this model will be helpful. So in our work here at the school, we're teaching and emphasizing cultural humility versus cultural competence. So on the left-hand side, it's what we have been doing for a long time. And on the right-hand side is the direction that we're trying to shift in, right? Instead of being, using this language, cultural competence, which suggests that you're supposed to know something about every culture. And because this particular group of people looks or acts this way, this is what you do for them. You have a canned approach for different populations of people. And I remember when I was going to like hospital mandatories and trainings and in-services, I go to these cultural competence trainings and we would be told, well, if you have a person from this part of the world, or if they speak this language, or if they represent this particular group, then this is how you treat them. Oh my goodness. We thought we were doing the right thing, but we were causing more harm. So how do we go from cultural competence to cultural humility, recognizing that each person that we encounter has a very unique narrative, and we cannot make assumptions about that person. But we're human. It's normal for us to do that, but the beauty about us being human is that we can cognitively intervene, and we know that bias is real. So it just means stepping back, listening to the patient very carefully, and asking questions and learning how we can best serve that individual versus thinking we have all the answers. Create and versus co-create. I remember when I was working for MedStar, we launched a new signature program that was called Hair, Heart, and Health. And I remember our leadership suggesting to me that we need to go in and we need to fix this community. And I'm like, wait, that's not how we do this. No. We cannot go into a community that's already having trust issues with us anyway, because we are a big health system. And when you look at all the people who've been leaders in this position, they don't look like this community. So no, we don't go in and we don't go in and create for this community. We co-create with the community. Or we could take it even further and say, we back down, it's the community that's actually leading the work. We're providing some support. So shifting how we talk to community members, to patients, again, exercising humility and leaving that whole paternalistic mindset. We need to get out of that as an industry and recognize that it's time for us to listen to communities and use our resources to help communities find their own way. I already talked a little bit earlier about biomedical versus biopsychosocial. We're very biomedically focused, and that's why we're spending so much money. There's money in sick care. People make lots of money off of illness, and that's very, very unfortunate. But if we truly are committed to prevention and wellness, we think about the whole person, and we have mechanisms and systems in place to support that. And we have ways to pay for it. And that's what we're doing here at the School of Health through our health economists. We're exploring ways to how do you pay for prevention? What's the business case for it? Because for some folks, they need to see the business case. They don't have the moral, motivation, unfortunately. So we find different ways to meet people where they are. And then implicit bias versus systemic bias. I know that you all have taken the implicit bias training. And a lot of times when we talk about implicit bias, we're talking about individual bias. But that is an issue, and work does need to be done in that space. But we also need to recognize that we're operating in an ecosystem that has bias in it, very naturally. And so let's think about that and what needs to be done to dismantle the bias that we see in our organizations. And I would love to hear how that's showing up in some of the organizations in which you're working. So I'm going to wrap up with this slide here. I'm on the DC Hospital Association board, and we have been working for the past 2 years on a comprehensive health equity framework for, again, all of the DC hospitals. And this is what we've all agreed to. All hospitals have agreed to do work in this space. And you can see, I'm sorry, this is probably too small, but yeah, but I'll tell you. So accountability is the very first one, ensuring accountability. And then we have some specific strategies for how we're going to do that and what the outcomes will be. So this is more like for our boards of hospitals and for our senior leadership. That's at the very top, right? We can't do this work without making sure that there's accountability. And so the presidents of all the hospitals have signed off on this, very committed. Mitigating bias, diversifying leadership, developing workforce pipelines is the fourth one, purchasing and investing locally. And I think, Mandy, you asked me to talk a little bit more about that, and I'm happy to do that. And then addressing social needs, which is the space that we're in. So purchase and invest locally. Let me give you a perfect example of just something very simple we can start doing. When I became dean of the school, I was talking to my team, and when we were always purchasing like food, and we have these events and receptions, and we're always ordering food from like Panera and Starbucks and these corporations. And something that we can just do, while I love Starbucks, and we can contract with small businesses in DC, particularly those that are located in the communities that we're always talking about, right? That can really make a difference. It can be transformational. So if we have a small business in Ward 7 that has a big contract with Georgetown, that's a big deal. And that is improving health. That's helping to improve the health of that community. So there's different ways that we can think about purchasing and investing, but I'm always challenging my colleagues and the folks at the DC Hospital Association to always think local. Think about what resources exist in our local community. There are amazing assets in every ward in the District of Columbia. There are amazing assets in Ward 7 and Ward 8. It is our Ward 5, again, all wards in the community. I don't want to just pick on Ward 7 and Ward 8, but I know that's where a lot of the pain is, and a lot of the trauma, and a lot of the health data that we're always seeing that we want to do something about, right? Know what those assets are. That's our responsibility. Know what community-based organizations exist in those communities. Find ways to partner with those community-based organizations, and partnerships can look in different ways. You could have folks who serve on their board. You can have volunteer work that's being done with those organizations. You can contract with those businesses. There are many ways to think about it. But what's most important is that we're canvassing and we're doing asset mapping of our own city or community or region. And we are thinking locally and knowing that that is going to help uplift the state of communities, which will ultimately translate into improved health outcomes. I think that's, oh, no, one more. So I know this was also in the packet. This is work that's been done out of San Mateo County, I believe in, San Mateo County in near San Francisco, I think that's where it is. But these are the 10, they've identified 10 components of equitable communities. And they start off with a healthy, stable, and affordable housing, because we know housing is healthcare, complete neighborhoods and communities, high quality education, thriving and an inclusive economy, healthy food access, active transportation options, safe and diverse public places, parks, and open space, sense of community where everyone feels like they belong and are safe, clean environment, and community-based public services and infrastructure. So these are 10, these are wonderful, wonderful attributes of a community. I think when I look at them, I think some of them can be consolidated, but I think that you can't go wrong. These are all very, very important, and they do reflect that first image that I shared with you earlier during my talk around the different characteristics that shape our health, recognizing that clinical care is just about 20%. And I think that is my last slide. Yep, so I'm going to stop there. And yeah.
Thank you so much.